Hi, my name is Andrew Hung. I am the director of the Center for Robotic Simulation and Education here at the University of Southern California Institute of Urology. I'm here to share with you our work in automating robotic surgical assessment with artificial intelligence. The work I'm going to share with you is supported by the National Institutes of Health here in the United States and an Intuitive Surgical Clinical Research Grant. So I'm going to share with you three different areas. The first is our work in automated performance metrics and the application of machine learning algorithms to process these metrics. And finally, some of our new work in surgical gesture recognition. For the last 3 to 4 years, we have recorded robotic prostatectomies by video, but also synchronized systems data recorded directly from the Da Vinci system. This includes kinematic data, or instrument kinematics, as well as system events. And it's from this data that we have derived what we coined automated performance metrics. These include the simple metrics of active moving time of instruments to the more sophisticated ones of wrist articulation of the instruments. During this talk, I will go through the evolution of our metrics from summarizing automated performance metrics over the course of an entire operation to summarizing them during each individual step of the prostatectomy to our most recent work, which is looking at the detailed automated performance metrics per individual surgical maneuver. This was our first paper validating or describing the validation development of automated performance metrics during live surgery. It's the first time we illustrated and quantified what expert versus novice surgeons look like during live surgery. This is the same exact step of the prostatectomy, just done by surgeons of different experience. These are the tracings of the instruments and the endoscope, and clearly there is a big difference here. We then looked to machine learning to process these automated performance metrics. With the wealth of data, how else could you process and derive insights from such a vast quantity of data? And here we wanted to anticipate clinical outcomes after prostatectomy. So this is when we were summarizing our metrics over the course of an entire operation. This is what we did. For 70 prostatectomies, each case we recorded a set of automated performance metrics. And we've labeled them with clinical labels. In this case, the length of hospital stay after surgery. Most patients stay in the hospital for 1 or 2 days, but some do stay longer than 2 days. We wanted to determine who these patients were. We trained a random forest model, and with the trained model, we plugged in brand new cases, never seen before by these models, to predict the hospital length of stay. And what we found, to our surprise, in this very initial study was that we were able to predict up to 85% accuracy how long these patients were going to stay in the hospital for. We then wanted to predict something a bit more sophisticated, urinary continence recovery. Most patients after prostatectomy will leak urine, and it's over the course of weeks to months that these patients recover that continence. And so instead of reporting these automated performance metrics over the entire operation, here we were now siloing these metrics in each of the 12 individual steps of the prostatectomy. We know that the prostatectomy, for the outcomes, there are patient factors and there are surgeon factors. And again, we looked at one of the three major outcomes after prostatectomy. For patient factors, we looked at 16 patient and disease-based features. Surgeon factors, we looked at 41 automated performance metrics reported in each of these 12 steps of the operation, with a total of 500-some features per case. Trained a survival analysis model to predict time to continence recovery. Using 3 different models, a conventional model, a machine learning one, and a deep learning deep serve model, we found that the deep serve, using both the surgeon and patient factors, gave us the best concordance index and the least error. We also were able to feature rank and determine which were the most important steps in delivering us the correct, giving us the correct outcome. And we found that of the top 10, all of them were surgeon factors. They were all automated performance metrics. 5 of the 10 were automated performance metrics during one very specific step of the operation, the vesicourethroanastomosis, which is the suturing step of the prostatectomy. And finally, of the top 5, 3 were automated performance metrics having to do with right instrument articulation. And now, finally, going down to where we are now, we are looking at what we call detailed APMs, or these are metrics summarized in each surgical maneuver. We've broken down suturing into 3 phases. There's the needle positioning, then the needle driving, and then the suture cinching. We did not introduce the concept of RACE, but we've incorporated RACE, which is Robotic Anastomosis Competency Evaluation. This has been published and validated in the literature. This is a manual measure of suturing technical skill. So applying a similar concept to what I just showed you earlier, looking at summary automated performance metrics. Again, these are APMs summarizing each of those 12 steps of the operation versus just looking at one step of the operation, but looking at the detailed APMs summarizing the kinematics or events during these discrete surgical maneuvers, or looking at RACE, the technical skills, which actually, if you look at the C indices, gave us the best performance in its ability to predict time to urinary incontinence recovery. And then there's the patient factors. If you take a combination of the detailed automated performance metrics with the technical skills and patient factors, it's given us the best concordance index to date. So I do want to touch on 2 other studies. These are our most contemporary work in gesture recognition. This is the deep learning-based computer vision to classify suturing gestures during robotic surgery. This is work that I've been doing with Dr. Anand Kumar from Caltech. We focused on the prostatectomy. We focused on the suturing step. We've looked at where in the anatomy people have thrown their stitches and what are the suturing steps. And of all the 3 steps, we've focused on the needle driving. And we know that people do it different ways. So they use their right hand, they use their left hand, they use a combination of these different gestures, depending on where in the anatomy they are. And in essence, the gestures differ by which hand is being utilized, the wrist rotation, whether it's clockwise or counterclockwise, and finally, the grasp of the needle, if it's overhand or underhand. So looking at a 5-way classification of the 5 most common gestures being utilized in a 2-step process, both for feature extraction then for classification, we now are able to predict with a 70% accuracy the gesture that's being utilized. And finally, this is more aspirational, but this is kind of foundational work to more AI stuff we would like to do in the future. We've looked at a different operation. We've looked at tissue dissection. And in the renal hilar preparation of the partial nephrectomy, we've created this dissection gesture classification. So in this very specific step of the operation, we know that 57% of the discrete surgical movements are for dissection. The rest of it is supporting. So of these dissecting gestures, there are blunt dissection moves, there are sharp dissection moves, and there are combination movements. And we know that from our initial work here that expert surgeons compared to novice surgeons are more efficient with these gestures, but further, their choice of these gestures are different depending on where anatomically the surgeon is. And so this is really exciting work that we are going to pursue further. This is our team, and I thank you so much for your time and attention.